Yes, your biggest sexual organ is your brain. It's been stigmatized for so long to talk about it, but that's also why people suffer longer than they need to. And also super common for these people to have been told that, well, there's nothing wrong here, you just need to relax.
I need to check my preconceived notions because I automatically go to the female anatomy, only a woman problem.
This is your right now, but it doesn't have to be your forever.
Today we are having a real conversation about things that people usually don't talk about, and that topic is pelvic health. Let's just start at the beginning. What is pelvic floor PT? I feel like when people think of pelvic floor, they often think of urge incontinence, leaking, but it's so much more than that.
The big idea that we want to get out there is that everybody has a pelvic floor. It's not just postpartum women. It's not just women. And there's a lot we can do for a lot of people of all different ages that can help improve their quality of life. We've got maybe like a little bit more knowledge about urge incontinence out there. But what we always hear with that is like, well, I'm doing my Kegels and it's not working. So pelvic floor PT, I think, has been lumped in with Kegels for a long time. And it is so much more than that. So much more than Kegels. It's so much more than postpartum women. It's anything that has to do with your bowel, bladder, or sexual function. Your pelvic floor muscles are heavily involved in all of those things. And that means for us as PTs that there's a way in to help with those things. We see men, we see women, we see older people, we see younger people. Anybody can have a bowel or bladder dysfunction. Mm-hmm. And then when it gets into things that maybe are a little bit more specific to your gender, such as sexual function, there are things we can help on both sides of the spectrum there as well.
Another thing I'd add too is your pelvic floor, I think, a lot of people don't realize is one of your main core muscles.
Absolutely.
So your pelvic floor is a group of muscles at the bottom of the pelvis, but the pelvis is part of our core muscles. So when people say, oh, I think I just need to work on my core, often it's this huge missing piece, like we're trying to do sit-ups and things like that. And often we see people where that actually causes an issue.
Right.
So maybe you're not leaking, maybe you don't have a bowel problem, maybe you don't have sexual dysfunction, but you do have a muscular issue that's causing pain in your pelvis too. So just that piece as well is a really important thing that we address as well.
Even talking to our other colleagues, our physical therapy colleagues, I think there's a lot of things that people are surprised that we treat. And that was another reason why we wanted to talk to somebody about this, because it's like, oh yeah, like we can treat that. We can help with that. In general, what we want to get across, well, I mean, I'll say my top two things and then you can kind of chime in. But like nothing is TMI for pelvic floor physical therapy. We've heard it all and then some. If you've normalized something around your bowel, your bladder, your sexual function, if you've rearranged your life around it, if you've kind of been like, well, that's just the way it is, that might be worth a second look. And a lot of those things we can intervene in. Maybe we won't be like a magic fix, but there's so much room for improvement with all of these issues that I just think it's so important to get that information out there.
Yeah, absolutely. Yeah, I think that's definitely, I wouldn't add anything to that. Well said. I agree.
But nobody likes to talk about it. So that's, that can be the problem, right? Yeah. We know this, but if people aren't talking about it, they don't know that there's something we can do about it.
Yeah, absolutely.
Well, I thought we would talk about the bladder first,
sure,
since this is really the topic that many people go to in their minds when they think of pelvic floor.
And maybe easiest to
feels like the most acceptable, right? But I'm sure there's still a lot people don't know. What can you tell me about urge incontinence or anything related to the bladder and pelvic floor health?
Yeah. Well, I think this is a great place to start because, we were just kind of like joking about this before we started. Like, who at this table hasn't heard somebody joke about leaking after having kids? Or like, well, that's just the way it is. I have kids and I just can't do the jump rope anymore. Those are things that have been kind of normalized. And it's a real easy one to kind of debunk right off the bat. Like that stuff that's a perfect example of common but not normal. Yeah. So, I've had kids and I can't jump anymore. That's like something that we can absolutely treat.
Right.
And then there's a couple more things we hear all the time that wind up being things that people don't realize that we can treat.
I think a lot of people justify their urge incontinence, meaning an urge incontinence being
Right.
when you have a strong urge to urinate, and the urge is so overwhelming to you that you can't make it to the bathroom on time. Like we wouldn't be able to have a conversation right now. You would be bolting out of the room. It's like your worst nightmare if there's a line
Yes.
at a public restroom and you leak on the way there. Or you get there and you're about to pull your pants down. You
made it.
all the way there.
Yeah.
Oh, but you just can't make it.
Yeah.
You're so close. So
Yeah.
that's a very simple explanation of urge incontinence. But a lot of people justify it too. You know, you probably hear this. I'm like, well, I just drank a lot.
Yeah.
Well, I was just focused at work. I've been working from home. I've been sitting a lot. I've been consumed with that, and I didn't listen to my urges. And so, well, of course I leak. So isn't that normal? It's like, no. Sure, those are circumstances that can cause or lead to this, but there's something going on inside of your body making you more susceptible or prone to this.
Sure.
And that's what we kind of dive into and talking about root cause and things like that.
Yeah. And have you ever heard somebody say like, oh, well, I just have a small bladder?
Yeah.
Right. But that's almost never true, that somebody actually has a smaller size bladder, right? Like your bladder, in general, a bladder holds, 10, 16 ounces. You should be able to make it 2.5 to 4 hours. That's kind of across the board. It's very rare that I've ever seen anybody actually have like their bladder doesn't have that kind of capacity.
Right,
It's a learned behavior.
Yeah.
Right. So what's usually happening is that your bladder has been trained to signal that urge too early, and you've listened to it repeatedly, and then that has become your new threshold.
Yeah.
And then there's things that reinforce that, like peeing just in case, restricting your fluids. All those things can kind of
contribute to the problem.
Absolutely.
And so like when I tell my daughter like pee before we leave the house,
Right.
like I'm adding to the problem.
Well, I mean, there's a little nuance there, but I feel like that's where it starts,
That is
right?
often where it
That's where it
starts,
starts. And I think that, a kid is learning, and that can be a different situation. But when those habits kind of extend past that time,
Right.
that it becomes a problem. And I've been guilty of it myself. I mean, I'm going to go just in case. I don't want to go at the grocery store. I'll go just in case. But like, you could always go at the grocery store. Like, it's not that big of a deal, but it's when it becomes like this habit that it's a problem.
One thing I often will say is like your brain is a much more larger, complex organ than your little bladder
Yes, it
is.
is. Yeah.
So please don't let your bladder control your life.
Yeah.
Like you have power over this.
You do.
Over this organ. So let's exercise that voluntary portion of it. There's a lot of involuntary processes happening here, but let's use our brain in that, like, I can make that decision of, am I going to go now or at the grocery store? And the ripple effect is very positive. So
Yeah.
So there's a psychological component to this.
Absolutely. Yeah. I mean, most things with our body have, a brain component to it.
Yep.
And I kind of say the same thing that Courtney does. Like, you have to teach your bladder that you are in control of your bladder. Your bladder is not in control of you.
Yeah.
And like that can go into some of like the next common things that we hear from people too. Like, I know where every bathroom is between here and work. Like, I have it mapped down in my head. So if I have to go, I know where I can go. What is it like? We always hear stewards. Everybody knows that that's where they can go, right? It's a decent bathroom.
They do a great job.
They do a great job. But like, if you have that in your head, if you're going into every single workday you have with that like planned out in your brain, that's a problem. That's not just like being prepared. That's a problem.
Yeah.
Yeah.
Travel too is common for people to, speaking of the brain and just bringing in the nervous system component to it, driving the urgency or frequency of, I'm about to get on an airplane and we're urinating 4 or 5 times before we go, or I'm about to fall asleep at night. Let me just go one more time. Let me just go one more time. That's
your brain.
Yeah, that's often the nervous system being more elevated or upregulated, so to speak.
Probably from years of little things that weren't even thinking about.
Right.
Well, and I've heard some women say, like, sometimes they feel like even though they've just used the bathroom, they still have that, like, urge to pee again. And
Yep.
so, like, is that a situation where, like, a woman's not fully emptying her bladder?
That's a great question, because it could be really one of two things. It could be that she's not fully, or she or he is not fully emptying their bladder, or it could be some missignaling going on between the brain and the bladder. And it's part of our job to figure out which of those problems it is, and then, make your plan of care accordingly. But either way, there's usually a place we can intervene there.
Yeah, that was a great question, because I think in the male population too, that's a big population that we see is actually incomplete bladder emptying. Where they go to empty and maybe they're dribbling a little bit more after because it's not fully coming out in that one flow. Their stream has changed, so it's like start and then it's stop and it's start and it's stop and it's like, let's get a little more out.
Yeah.
And it's taking them a long time to go in the bathroom, or it's like just a power hose.
Yeah.
And then it stops.
Yeah.
I need to check my preconceived notions because I automatically go to the female anatomy. Like, this is only a woman problem.
True.
But I'm sure you see just as many.
Yeah. We do. I mean, I think it's more, we were talking about how, like, people don't talk about this stuff. It's probably women who talk about it more.
Absolutely.
It's probably even less talked about in the male population. But most of these things that we talk about are across the genders. Like I said, when we get into sexual function, there are some differences. But, these things that we've heard about urinary symptoms so far, it's both. It's really both.
Yeah.
And to kind of touch on something that you just said about their stream changing, incomplete emptying in the male population, some of that gets dismissed as aging too, right? Because we know that there are changes in the prostate that happen as we age, but it doesn't necessarily have to be as dramatic, and it doesn't have to be something that we just accept as part of aging. And of course, as women, we've been told a lot of times that, like, our problems are just due to our age or our hormones or this and that. And that's just an example of it happening to the male population too.
Yeah. And just to kind of close this loop too on I got an example that just popped into my head. Like, wonderful gentleman I treated, he was in his 80s, and he had frequent UTIs. This guy had been on every antibiotic under the sun, causing other issues for him. And his urologist had kept saying, well, you must just not be emptying your bladder well. And he's like, I've never had an issue with that. And, often what happens is the urologist has run through the gamut and then says, well, I guess try pelvic floor PT.
Last
So he came to me, and lo and behold, over some time, he couldn't believe how much urine was coming out of him. And he had no idea for over a decade that he wasn't emptying his bladder well. And he kept getting these UTIs, and the UTIs resolved because his bladder wasn't holding urine anymore.
And so even at 80, we can see improvements with some treatment.
Yes. Yeah. Of course, he had gone through a full medical workup at that time as well. But yeah, exactly.
Yeah. And, speaking of kind of aging too, not to kind of go down a rabbit hole, but we mentioned hormones briefly before with women. There's sometimes an onset of urinary symptoms around menopause that is kind of just treated as, well, that's it. It happens. Like, here's a pad, and, be on your way. That's why, like, there's so many aisles of incontinence pads at the grocery store. But there are ways to work on that, even when there's a hormonal component to what's going on. First, is somebody managing these hormones for you? That's a great question. And that's been a huge improvement of quality of life for a lot of my female patients in menopause, is just getting somebody to take care of their hormones. We don't want to mess around with UTIs. UTIs can land you in the hospital. And if it's, sometimes it's as simple as getting on the right hormone and you're good. That combined with a little bit of coordination and support from a pelvic health PT can make a huge difference.
So last topic related to the bladder, like, waking up to pee in the middle of the night, is this something that's normal?
Yeah.
Should I be able to make it through the entire night without waking up for this?
question. And it's also something that you're kind of told at a certain age, like, well, that's just what happens. But I would say that getting up multiple times is not normal, right? I mean, if you're pregnant, that can be a little bit of a different story. But when you're older, 1 to 2 times, but beyond that, really it requires some investigation.
Yeah, absolutely. And even that too, we've seen that might not be the primary thing people are coming in for, but they find that as their pelvic floor health has improved, like, I slept through the night for the first time.
Yeah.
And we hear that a lot, so we can't guarantee that, but sometimes these things are overlapping so much that it is usually improved.
Absolutely. Yeah. And I always ask too, like, are you being awoken by the urge to pee or by something else? Which also gets us into their kind of sleep hygiene, and that's just so important for overall health. So is it a pelvic floor problem? Is it a sleep hygiene problem? And that's stuff we can offer education on as well.
Yeah, I think that's a good point too, of like circling back to your first question of like, what's the pelvic floor and kind of what do we even do? One thing is like talking about kind of that lifestyle health. Sleep. We want to know like how you're sleeping, stress, just to name 2 things, how often, what your bladder habits are, things like that, and how that's playing a role.
So much more than Kegels.
So it sounds like a patient who might come in for that initial conversation it's going to be more holistic than just pelvic floor health.
We hear a lot that we ask questions that they haven't heard before. And I think that that's really important.
Yeah.
And we're very curious. We ask lots of questions, and we're trying to treat this holistically, not just as a pelvic floor problem.
So we want to venture into more uncomfortable territory.
Yeah, let's do it. We're ready.
Let's talk about poop.
Yeah.
And we don't, right? Like, my husband and I joke, like, I don't poop.
Nope.
Right? Like, and I think a lot of people have that stance.
So you're a miracle.
I think, it's a conversation that can be anxiety inducing for a lot of people, embarrassing for a lot of people. And so, tell me what these conversations are like from a PT perspective.
I mean, super normal to be nervous about this. I feel like it's been stigmatized for so long to talk about it, but that's also why people suffer longer than they need to, right? Some of this stuff goes back to, I've heard patients who have had bowel problems since they were in grade school because they refused to go poop at school, right? And then that has snowballed into something in their adult life. So it's incredibly common, very treatable, and the pelvic floor is kind of right in the middle of bowel function. Once you get past that initial awkwardness, people are usually relieved that we are asking these questions and we are going through these things. I mean, we are asking how often, what your urge likes, what it is like, what does it look like in the toilet, like how long do you spend on the toilet. We're very curious, and it's another instance of there's really not too much information for your pelvic floor physical therapist. Some of the things that we hear, like the way the conversation goes for us, and this one was funny enough when I mentioned briefly before, we had this, continuing education with our other PTs. And this one kind of like brought the house down. They were like, what? That's not normal. If you have to wipe endlessly after a bowel movement, if it's not just a wipe or 2 clean, that's probably a problem. And the whole room of PTs were like, what? So
we need to talk to you.
Do we need to have an intervention? Yeah. So that's, you're having an incomplete bowel movement there.
So you might not be fully emptying in that sitting, and so you're having to continuously wipe what's still there, basically.
And sometimes it's a consistency problem, like what is actually the state of your stool. And certain consistencies are going to be harder
the state of your stool.
The state of your stool. I'll have a state of your stool. So that can influence, how clean of a bowel movement you can have, obviously. And, I'm not fiber. I can't change the consistency of your stool in that way, but like I can talk to you and educate you about things that you can do in your lifestyle that can help contribute to better state of stool, right? And then we talk about the coordination problem that can be involved, because sometimes it's not just the consistency of your stool. Sometimes it's your pelvic floor not fully relaxing to allow this to happen. There's also pushing mechanics of how you evacuate stool. It shouldn't be that much of an effort, but there is a coordination of things that have to occur. And that's something that we can intervene in. And then people wind up straining harder or wiping. And both of those things can lead to more irritation. And again, this kind of snowball effect of contributing to the problem further down the road. We talk about positioning of bowel movements a lot. Do you guys have a squatty potty at home?
I've heard of those. Yes.
If you don't have a squatty potty at home, most people can benefit from it. The reason
Toddler step stools also.
toddler step stools.
Yeah.
Yep.
So
Yoga
how
mat.
does that help?
Yeah, exactly.
So it actually changes the angle of your rectum, and it actually changes the position of one of your pelvic floor muscles. So again, shout out to Squatty Potty, but
Yeah, I know. Yeah.
they have a great example of basically showing, imagine like a lasso around the rectum. Okay, so we have like one muscle that's.
Oh, we have a rectum.
Oh yeah, we do. You know, like my hand. We have a rectum. It's here. So you can see the angle here, right? So just by the way that we are sitting in the position of our pelvis, it actually will change this angle. So when we sit on our big American thrones, it actually puts this at almost like, we could put it almost at like a 90-degree angle.
Yeah.
So if you can imagine, like that's a lot more force
Yeah, you
that
gotta
has to
take
go
a good
down to
turn.
have it go, you know?
Right.
So just by getting your feet up into more of like a squat-like position, sitting on the toilet, that helps change this angle. So, my formal words are, it's more of a straight shot.
Yep.
And then the other pelvic floor muscle, which is a voluntary muscle, which means we have some control over it, called the puba rectalis, actually slings around this as well. And so getting your feet and your hips in that certain deep squat position puts that more on slack and less of like a tight lasso. So basically it just makes it easier.
Yeah.
And often we make it harder on ourselves than we have to.
Yeah, definitely. And, we spoke about, she mentioned the hips and the pelvis. I mean, physical therapists, that's what we do.
Right.
We can help your hips and pelvis get into a better position to make these things easier, because where your pelvis is living in space, how well your hips move, all can affect these muscles. And I think the squatty potty is a really great example, a really great concrete example for people to see that. The position of your hips will either make your pelvic floor work for you or against you.
And that pelvis and hip treatment, that's external, right?
Sure.
Yeah.
Yeah, absolutely. And I think that's a common misconception about what we do. And I'm glad you brought that up. A good pelvic floor PT knows how to evaluate the pelvic floor internally. That's what we're specially trained to do. And that has a role, and that can be really impactful in the coordination training. It can be really impactful with tissue tension. But so much of what we do is outside of that little pelvic floor window. We are working on your whole body to integrate it into your system.
Exactly. Yeah. And that's a great question. If someone is not comfortable doing internal work, there's a slew of other options from A to Z, basically, that those roads we will go down to try to find healing through that way.
Yeah. And a lot of time with bowels, with bowel dysfunction, I mean, just the basic education, some, abdominal bowel massage that we teach people, squatty potty, breathing, that can make a huge difference in the beginning. Sure, there's more things we can do, but that can be like enough for some people to really get through their day. So even if we don't approach things internally, it can make a really big difference.
Yeah.
To move forward, you must hear a lot about like what goop looks like.
Yes. We do. The state of the stool.
No such thing as TMI.
Yep.
So what are some other problems that you frequently hear?
You're gonna hear things about the consistency of the stool that indicate if you're getting enough fiber. There are those things too, like, right, like how well formed it is gives us an idea of what's going on in the gut. But if we're talking about things that are happening mechanically at the pelvic floor, specifically, we hear about skinny stools, pencil thin stools. That can be a red flag for colon issues. So you mentioned before, like, make sure people get these full workups and are supported by their doctors. But if they've had colonoscopies and they're normal and you're still getting this super skinny stool, that can be a problem with that muscle that we just talked about. And it kind of piggybacks off the idea of the exit being choked off a little bit. So it has to go through a smaller opening, basically, because the pelvic floor muscles are not relaxing in the right way.
Yeah. I think too, just kind of zooming out from what you said and other bowel issues, poop issues, just thinking like our digestive system starts here. It starts in our mouth, which you've mentioned, like fiber, water, etc. And then, you can think about it ending as like the pelvic floor being the outlet or the final. So part of our job is to figure out where your problem is showing up. We're not dietitians, we're not colorectal surgeons, but kind of part of what we do is gatekeeping in that sense, is like, hey, I've been to GI, or maybe you haven't, and there's direct access and you can just come in for an evaluation. And part of our job is differential diagnosis, which is just a fancy term for like, is your problem in our wheelhouse or not? And is it, we need to work on your coordination, your pressure, your old scars, which I'm sure we'll talk about, things like that, your breath work. Or is it like there's some flags coming up here and we think a colonoscopy or seeing a GI is your first things first, or we should really get a dietitian on board here.
Another example of things that we hear that are kind of more multifactorial and a place where we kind of play quarterback is when people come in with bloating. I feel like bloating is everywhere right now on social media. I feel like it's like one of those things.
Hot topic.
I think it is. I think it's trending. I think the kids are talking about it. But what it is like people feel bloated all the time. They maybe get a little relief after a bowel movement, but then it comes back. They maybe wake up with a flat tummy, but then later on in the day, they feel bloated. People often find their way to us because they've exhausted a lot of other possibilities of what it is. And not all bloating is pelvic floor related, but it can certainly play a huge role in it. And I feel like we both have had a lot of patients with this complaint recently, both male and female. Actually overwhelmingly male lately.
Not usually diet related.
No, not usually diet related. And some of these people have been to like really thorough nutritional evaluations and they don't necessarily have sensitivities or anything like that. So when that's
or they do, and they're addressing it with, we've got a team of people on board and we're addressing it, but there's still an issue.
And where we fit into that picture is chronic pelvic floor tension is going to affect mobility through the digestive tract. And this goes back to what Courtney was mentioning, how our pelvic floor plays a role with our core. So our core is a canister. We've got our diaphragm on top, we've got our pelvic floor on the bottom, we've got abs and back muscles. There's a really intricate dance that goes on between all of those. And if there is an issue with coordination anywhere in that canister, what happens is it impacts the ability of things to move through your digestive tract. Your breathing, this like pump that happens every time we breathe, all the way from your diaphragm down to your pelvic floor, that's moving things through the system. And if that's not happening, that can cause bloat because pressure's got to go somewhere. And if we're not getting that nice normal pump that's supposed to be there, pressure shows up. And then if these things have been around for a while, nervous system, like we mentioned before, we get this hypersensitivity in our organs. We get hypersensitivity in the gut to normal sensations, to normal distension of our gut. And that is where our nervous system treatment comes into it. So not every case of bloating is pelvic floor, but when it's combined, especially when it's combined with other pelvic symptoms, or you're kind of exhausting your other options, it's absolutely worth looking at.
Yeah. And one thing too, I'd add, like, kind of a little bit on the, the TMI topic, but the things that people don't like to say about this, I think, is that when they feel bloated, they end up trying to hold in their belly more, or wearing more restrictive clothing to try to hold it in, which can in turn actually cause more of an issue, and it's kind of this vicious cycle.
No Spanx.
Oh, well, listen,
question.
I love my Spanx when I need them, but I'm not going to make a habit.
High-waisted jeans.
No, not an everyday thing. And that's something, like we mentioned, women joking about, peeing after sex. I mean, how many, like, we grew up being taught to suck in our stomachs, right? Like, that's just something that's been normalized, I feel like, and people are very sensitive to that.
Yeah.
And that's a hard thing to address with people, to let their stomach go.
Yes.
Well, I feel like this is a good segue into the next aspect of pelvic health, and that's sexual and reproductive health.
Yeah.
And so I'm sure you see a wide range of topics here, from painful periods or painful sex or erectile dysfunction. And so can you speak a little bit to some of the common issues that you see in your treatment rooms?
Yeah. Super common. And also super common for these people to have been told that, well, there's nothing wrong here. You just need to relax.
Have a glass of wine.
Yes. That's what we've heard over and over. And I think, we're taught from a young age that these things are kind of private, maybe shameful, not something we're talking about necessarily. I mean, doctors sometimes don't even ask about it, really. Even GYNs sometimes don't even ask about, like, the quality of your sex life. So people suffer quietly and assume it's just normal. And this is where, with a lot of patients, I feel like we get, we tell them that it's not normal, and their eyes just sort of like go wide, and they're like, wait, it's not normal? Like, I thought this is what everybody felt. There's almost always something driving painful sex that we can help with, I would say. It depends, there's lots of factors that go into it, but that's almost always something that can be helped with pelvic floor PT.
I'd say probably with all the things that we're talking about, there's no silver bullet solution because of the vulnerability of, sexual health in general. There's usually multiple layers that we're addressing, but common things that we're seeing is painful intercourse. That could be for females, like pain with penetration. It could be non-penetrative sexual activity that people are struggling with.
Yeah, it could just be external stimulation can be painful too.
Yeah.
Or inability to have an orgasm.
Right. Or more difficulty to have an orgasm too. That's a big one that people are like, well, I thought that was just because I was going through menopause, or because, it's just been a hard year.
Or I just had a baby. Or,
so those are common ones for sure.
The idea of an orgasm, I'm glad we kind of went down that path, because that is something that, yes, your biggest sexual organ is your brain. Like, that is a thing, right? But these muscles that you can kind of see there on our pelvis, they connect right into your clitoris. And if those muscles aren't doing their job, that clitoris is not getting blood flow. And blood flow is so important in terms of sexual function. And this goes with male sexual function as well. Blood flow is so important. And if we've cleared your kind of cardiac issues with male patients, that could be a pelvic floor issue. It could be a muscle issue. So that is something that is worth mentioning, because I will say, even people who come into us for pelvic floor PT, sometimes that's the last thing that they mention. They've made the step to come to pelvic floor PT, but they're not necessarily telling us about their orgasms unless we ask them. It's on our very nosy intake form.
Yeah.
So it could come up,
Yeah.
but even people who have come to see us are surprised that that's sometimes. And that might be something you mentioned earlier, a surprise benefit of PT. People will come in and be like, sex was totally different. And that's just bonus, super rewarding bonus. But, to get into specifically some of the things we hear from our patients about painful sex, things that we hear that they've assumed was normal, but it's not. It feels like something's hitting a wall. It feels like something is tearing. It feels like something is burning. I have to ask my GYN to use a child-sized speculum for my exams. I can't put a tampon in. All of those things are not normal, right? And all of those things probably have a muscular tension component to it. Like you said, it's multifactorial. Nerves, hormones play a role in this for sure. But more likely than not, there's a muscle tension issue there.
Yeah, in the male world too, just like difficulty getting an erection, difficulty maintaining an erection, premature ejaculation, less, we'll get a little bit more into this later, but less like spontaneous erections. You're not waking up with erections anymore, and that kind of becomes sometimes a little bit of a domino effect down to difficulty in the moment as well.
I think to go back to our point from earlier, a lot of people just assume that that's normal with age, that I'm less sexually active or I don't perform the way that I used to.
And there are going to be some changes. Like there are things that happen with blood flow as we age, right? Like there are things that happen with our muscles as we age, but we shouldn't just accept that there's nothing to be done about it. Because even if some of that normal age-related changes are happening, we can optimize what's there. And we can kind of talk you through what's normal and what's not normal, because I feel like it all gets lumped in together.
For sure.
And that goes into something we often hear, which is like sex, and this is more of like a female talking, sex used to be fine, but now it's not. And that's usually, we're in our 40s, we're in our 50s, and things are changing. Again, hormones are blamed for everything. And that's something that we can address, the hormones. And we facilitate that conversation with their other doctors, right? It's an estrogen issue in menopause, right? And it can be an estrogen issue right after you have a baby too. Sometimes you have a baby and getting back to sex feels uncomfortable, and maybe it feels uncomfortable to start with first, second time, but then it should get better. If it's not getting better, that might be a hormonal issue. That might be a muscle tension. That might be a scar tissue issue if you've given birth vaginally. And then again, with menopause, estrogen. And I can say that for a good number of my patients, I've been the first person to mention that to them. So if sex used to be fine, but now it's not, talk to somebody about it.
Yeah, I'm glad you mentioned the estrogen and vaginal estrogen specifically, and vaginal moisturizers.
Yes.
I always say it's like chapstick for your vagina.
Yep.
Don't be afraid of it.
Okay. They even make it in a tube now. I remember when I was newly postpartum, it was like a tub and it was very messy and all of this. But now they make it like it's just like a little tube. It looks like chapstick.
Yeah. But even if people will say, well, I'm not really sexually active.
Right.
I don't really care about that, or I don't have vaginal dryness. But, well, you haven't been sexually active in 5 years. How do you know?
How do you stay connected?
That too. Maybe that desire isn't there. Right.
That's a good point. Yeah. And then circling back to our talk about like the bladder too, is that sometimes the bladder issues, especially in this phase of life we're talking about, perimenopause, postpartum, big hormone fluctuation time, sometimes that's linked to the tissue issue.
Yep.
So you may not be sexually active, or or that's not a value to you, but it is impacting the other systems happening in this area here.
And that goes back to the UTIs.
Neighborhood here.
Yes, it is. And the UTIs that we mentioned briefly before, right? That's a major health issue. And something that for females, estrogen can be hugely impactful.
I want to go back to painful periods.
Yes.
I feel like I have so many girlfriends who have like very debilitating periods, like can't get out of bed to work or whatever they need to do. It impacts their daily lives.
Another great example of common but not normal. And I'm glad you brought that up because, one of the things I'm pretty passionate about talking about is the underdiagnosis of endometriosis. And, again, we're not diagnosing people. That's not our job, but we very often are somebody who is facilitating a better understanding of people's health or better questions to ask their providers, that sort of thing. And if somebody tells me that their periods are that bad, it's the first thing I'm thinking, to tell you the truth. I mean, I got some other questions, but that's not normal. If you can't go to school, if you're calling out of work because your periods, whether it be pain, volume of bleeding, or both, that's not normal. And you don't have to live like that. Endometriosis affects, I think the numbers are now like 1 in 10 women, 1 in 9 women, something like that. And it takes people an average of 7 to 10 years to get diagnosed with it. Like, they start talking to people about their symptoms, and then it takes 10 years for them to actually get a diagnosis. I feel like tides are shifting with that. People are talking about it more. But that is really a red flag. I shouldn't say red, right? That's a yellow flag for us as physical therapists, that we're like, we need to get a team in on this.
Endometriosis is definitely a major contribution to painful periods.
Yeah.
But getting, other conditions that cause changes in your hormones are also worth a workup for sure. And then again, we're here to say, well, what are the controllable factors here? And we're here to intervene with that. A tense or a tight pelvic floor, or asymmetry in your pelvis, all of those things, maybe there's a nerve issue there. Those are things that we're also addressing that we'll see. Oh my gosh, I can't believe, we worked on that thing last week and my period was way better. So those are always exciting.
Those are super
So
exciting.
Stories to hear for sure.
I'd like to circle back to men.
Yeah.
And erectile dysfunction, especially with men who are otherwise healthy.
Right. Yes. And we mentioned this briefly before, but I'm happy to go into some more detail about this. So if a man's coming to me with complaints of erectile dysfunction and they've been checked out and they have a healthy heart, we're thinking about their pelvic floor for sure. We're thinking about how the muscles may be getting in the way of the blood flow that's necessary to achieve an erection, maintain an erection. And that could be because the muscles are living in a state of tension. When muscles are living in a state of tension, they don't get great blood flow. Their tissue health isn't healthy. They literally don't get blood to where they need to get it to. And it's all about blood flow with erectile dysfunction. Coordination too, right? Because these muscles, because even if you can achieve an erection, these muscles need to go through a complex series of contract and relax for ejaculation, orgasm. So muscles play a role with getting the erection, and muscles play a role with orgasm for men too. So if you've been cleared by your doc, I'm looking at pelvic floor tension and coordination for sure.
Absolutely.
We also have Shockwave at our clinic, which has been really it's been really impressive what it's done with erectile function. Again, people who have been cleared by their docs, it's been hugely beneficial in terms of getting blood flow to the area. So that's another thing that we should put out there more, is that there are options for erectile dysfunction beyond or in addition to medication.
Right. Absolutely.
And men will also come to us with erectile issues post prostatectomy. And that's not necessarily the same. We're not talking about the same path to dysfunction there. We're talking about like a surgical event that puts them in a position to be a little bit less successful with erectile function. And we are a great resource for those men. There are great surgeons out there who do these surgeries and remove the cancer. But you lose literal length of your urethra when you have a prostatectomy. You lose your prostate, which has probably been keeping you continent for years. You have to start using muscles that you didn't know existed prior to this surgery. And not all of that is necessarily conveyed to you when you have this surgery. You're sent home pretty much with a sheet describing Kegels. And we know, or we should know by now, that is not the full answer to pelvic floor dysfunction. There's a lot that goes into it.
Yeah. Yeah. You used that word optimize earlier.
Yes.
You know, it's like, but can it be better? You know, you have prostate cancer is the rate of that is really high. I have a number of like 1 in 8 in my head, but I might be wrong.
I don't know the
It's
number.
high,
But it's high.
but in particularly in America too. And so prostate removal is much more common. So like men, I just want to say like they're not alone. And you don't just need to do Kegels, but even coming in for 1 or 2 sessions.
Yeah.
To make sure are you doing it right? You know, what does your body need? Do you need 100 Kegels a day? Maybe not. And you know,
But are you doing 100 Kegels, but you're only doing them sitting down?
right,
Like they're
right,
like
or laying on your bed.
Right.
You know,
So there's like a lot of questions we have
Yeah.
for these people
Right.
about why what they're doing is working or not working.
Exactly.
And there's a huge window for improvement after prostatectomy that I think people don't realize. Like it's 2 years for those nerves to really reach their full potential again.
Right.
So sometimes I see guys just a few months out who are really down on themselves and down on their function.
Yeah.
And just a little education about how, okay, this is your right now, but it doesn't have to be your forever. And this
Right.
is what we can do to optimize.
Yeah.
It can be really important.
Yeah. Yeah.
Is there anything else with sexual and reproductive health that we haven't touched on yet?
People who say it feels like there's a tampon falling out of them all the time.
Yeah.
That feeling of like pressure or something falling out.
Something bulging. Their heaviness.
Yeah.
Yes. Those are the
Scary things to talk about. Nobody wants to talk about things falling out.
Yeah.
Right?
What is that?
Yeah.
We'll,
That sounds
we'll
serious.
definitely say that's one we'll see on the mom's blog page.
Yeah.
Yes. My doctor said, what is it? Is my doctor said I have prolapse, you know, and your eyes are gonna like fall out of your head, and your jaw's gonna drop to the floor because it's basically like, well, something's coming
falling
out of me.
something's coming out.
That's pretty alarming.
really jarring.
Yeah. That's understandable. But again, I'm throwing out stats, but basically there's like more research studies are showing that a high percentage of females have prolapse, but have gone, either they're just asymptomatic. So to just kind of like calm the nerves about it a little bit is that, well, a lot of people you can have prolapse
And not even know it.
and be asymptomatic. You can have prolapse and climb mountains.
Yep.
And run a
marathons.
marathon. So that's true, but you can also
Squat heavy. You can squat heavy. You can lift
Yes.
things because
Thank you for
people are
saying
told that they
Yes.
can't lift after
Yes.
this.
We've had someone with no symptoms and come in and be concerned about their prolapse and had stopped all of these exercises and the symptoms got worse. So we just needed to learn, how do you lift with a prolapse?
Yeah.
How do you manage your pressure so we're not pushing on things more? There are different stages of it.
Yeah. It exists on a spectrum.
Yes.
Right?
Yeah.
There are stages of prolapse, but your stage doesn't necessarily dictate your degree of symptoms.
Yeah.
Someone can have a low stage of prolapse and not even know it.
Right.
Someone can have a low stage of prolapse and it's really impacting their life. But so the stage, I don't want to say it doesn't matter so much, but it doesn't tell the full picture, right? There's a lot that goes into it. Managing coordination, managing intra-abdominal pressure, getting people into the gym if that's what they want to do, getting people running if that's what they want to do. That's where we can intervene. You can manage these symptoms pretty successfully. Do people need to have surgery for this sometimes?
Sometimes.
Sure. Yeah. But I will say what sets you up for success with these surgeries is addressing all of this stuff beforehand.
Yeah.
If you don't know your pelvic floor exists before the surgery, you're not going to know it exists after the surgery.
Right.
So, coming into pelvic floor PT, even if you've got it in your head that you'll need surgery eventually, is going to put you in a better position for wherever you end up.
Yeah. The surgery doesn't fix your muscles, it fixes the structure.
Yep.
And so that's a big piece. And that's true for your prostate removal, for a hysterectomy, for so many things. You're getting an organ removed from your body or tacked up.
Yeah.
We need to support the structures around that to probably do a little bit of the job that other thing was doing. And then another thing I would say too, on the prolapse is on the flip side of, maybe being told you have a grade 3 or something like stage 3 is the opposite of being told you're like, I am for sure, I can see it, I could feel it in these scenarios, and then going to provider and the provider saying that it's not there.
Right.
Right. And, so I say, well, think about the position that you're in on the table.
Yeah.
You're on your back, your feet are up. That's not the way you do your life.
Gravity's doing you a lot of favors.
I don't know, maybe you're in the minority, but I love that for you. But yeah, you do life squatting, or you're picking up your kids' stuff off the floor constantly, you're leaning over, you're lifting, like, show me that.
And that's another thing where I've seen people who've said, well, I've done PT, but it failed for my prolapse.
Yeah.
And if it's just been things that have been on the table, if your prolapse has only been checked on the table, if your coordination has only been checked on the table, that's not getting the full picture. I mean, we get people up and we check what's, when they're comfortable with it, we check what's going on during these symptomatic movements. And that can be a big eye opener.
For sure.
Yeah.
I'm thinking, and this isn't necessarily sexual and reproductive health, but I'm thinking postpartum women, like with C-section scars, like, is there anything that you can do to help women in that scenario? Great question.
I'm glad you brought up C-sections for a lot of reasons. One being the scars, because there's a lot of intervention we can do there, but also just to get the point across that even though you didn't deliver vaginally, your pelvic floor was pushed to the limit for your entire pregnancy. So having a C-section does not mean you don't need pelvic floor physical therapy, right? So I just like to put that out there. So when you give birth surgically, the scar can be an issue for some people. It can be an issue for some people in terms of sensitivity. They don't like to touch it. They don't like to look at it. I've seen people who have a painful C-section scar 20, 30 years later. I've also seen people who are very fit, very active, but they're like, I just can't get rid of my C-section shelf. Like that, there's always something hanging. And what they mean by shelf usually is you have like your scar and it's kind of pinned down. So their fat is kind of...
Or just skin,
right? A lot of times we're like, that's just skin. But whatever it is sitting on a shelf over the scar. And that is not a fitness issue. That's a scar tissue mobility issue. And for those things I mentioned before, sensitivity to touch, pain years and years later, usually a scar tissue mobility issue. Scar tissue has to happen. A C-section goes through a lot of layers of tissue. A lot of healing needs to be laid down. Your scar is not your enemy, but it needs to move with the rest of your body, right?
Yeah, well said. Scar tissue is created for a reason. To protect an area. Surgery is a trauma to the body. C-section is a major abdominal surgery, but we can have what's called adhesions, or like basically an overproduction of scar tissue that can lead into surrounding structures. I mean, like Sarah said, the scar kind of goes through here. We see a lot of people with hip pain later on, and that we find that when we actually work the scar, the hip gets better. I mean, I can not even touch near the hip joint, and we're improving because things aren't adhered or tethered or anchored from another part of our body.
I'm just thinking, like, I'm a patient who finally, like, I have one or more of these issues, and I finally decide to get an appointment. And what is that first evaluation like?
Well, we're very nosy. We ask a lot of questions. But no, we try as hard as we can to make it a very comfortable environment, because we know for a lot of people it takes a lot to get there. Some people hop right into our room and tell us their whole life story and then some, and that's great. But for some people, it really is a big step just to get to our room. So we want that first visit to make you feel really comfortable and listened to. That is our first priority. Because for a lot of these things, we mentioned it for I can't even count how many of them, people are usually just kind of dismissed with these symptoms. We're not going to dismiss you. We've heard these things. There's something we can do about a lot of these things. So the goal is make you feel comfortable. We have a conversation. We have a conversation about your symptoms. We ask you lots of nosy questions. And then we figure out, based on our questions, what we'd like to evaluate. And then I'll kind of spell that out to a patient, explain why. And if, based on our conversation and your symptoms, an internal assessment seems warranted, we'll discuss why that is. I pull out my pelvis. I show them what we're talking about. We discuss it together. And sometimes people are like, yeah, let's do it. And sometimes people are like, maybe not today. And sometimes people are like, never. And that's okay. And we kind of find a way to work with you and make you feel comfortable.
It's an hour-long session, one-on-one, in a private room. So it's an opportunity to share your story, and we'll probably ask more questions, like Sarah said, about that story. Sometimes we don't realize how much is related. We might be checking your neck range of motion. So it's not always, that we're going to go dive into the pelvis, but sometimes we're like, I'm actually a lot more interested in your shoulder right now.
How much
that's related to your pelvis.
About concussions lately.
In concussions.
I mean, there's so much systemically that can go on that affects your pelvic floor.
Yeah. So the assessment's very individualized, depending on the story that you share, but often a pelvic floor assessment is included if it's indicated.
I've heard the phrase quality of life a lot today, and it sounds like just, deciding to move forward with pelvic floor treatment has the potential to improve one's quality of life significantly.
And I think things that people don't even realize that can be improved upon, and the amount of times I've heard, I just wish I knew about this sooner. That's what kind of inspires me to get out here and talk about it, is that we should be getting to these things sooner. And I should be like, I should be a tune-up for you. I shouldn't be someone that you need to see every week for the rest of your life. You come in, we figure out the problem, we work on your quality of life, and I'm always here. We're always here because things change, right? But we're working for better quality of life for sure. So we have, we've got quite a few pelvic floor PTs now at Core, myself and Courtney, and we've got Talene and Katie, and we've got Brittany doing some pelvic health in Albany as well. So we have a lot of people ready to help you improve your quality of life. We're working on our education and social media, so you guys have some resources on our website that you can look into if you are interested in learning more about us. We have some blogs up there. We've got information about our backgrounds up there. And if any of this kind of sounds like what you're dealing with, we encourage you to reach out. We have, via our website, you can find a phone number to call us, to text us, whatever you feel comfortable with. And, we are also happy to hop on the phone for a phone call, like a little 15-minute phone consult. Does this sound like it might be something you can treat? We're available for that. And we mentioned before, we've got, Shockwave as a tool to help us. We've got PTs who utilize, we utilize biofeedback. We utilize manual biofeedback, hands-on, and we utilize machine biofeedback as well. And we have those options for you. We've got classes as options. We're trying to make this a really one-stop shop for all your pelvic health needs.
Well, thank you both for sharing your wide depth of knowledge and communicating what this is all about for future patients. I really believe in this. I think that you guys are doing great work. And I honestly, I think this is something that, postpartum woman, I think everyone should have access to this. When I hear of other countries who that have, adopted this.
It's just normalized.
It's just normalized, right? And I think that the American conversation around health, we know, is a little lacking. And so I think the more that we can do to raise awareness so that we have educated patients who can come to you ready to feel comfortable and take these important steps, I think it's wonderful.